Welcome to ACNL in Action, brought to you by the Association of California Nurse Leaders. I'm your host, Charlene Platon. Our guests today are Surani Hayre-Kwan, nurse practitioner, and a returning contributor to the show, and System Director for Advanced Practice Providers at Providence. We also have Sheree Scott, Clinical Nurse Specialist, and Associate Professor and Director for Clinical Nurse Specialist Programs at the University of San Diego, and Elizabeth Pulatie, Retired Certified Registered Nurse Anesthetist, Chief Nursing Executive Officer, and Vice President of Patient Care Services at Mercy Medical Center, Mount Shasta. Each of our guests is an advanced practice nurse who comes to the topic from a different specialty and perspective. We're having all of them here today to talk about what advanced practice nursing is and how it functions in today's healthcare and health policy environment. Thank you all so much for being here today. It's so great to have you all on the podcast. And I want to start first with talking about the term advanced practice nurse. And so, Elizabeth, I'm curious if you can help us when we say advanced practice nurse, what does that actually mean and what roles would fall under that umbrella?
Sure, I'd be happy to. Advanced practice nurse is a nurse with an advanced degree, at minimum a master's degree. Many have a doctorate degree. They've been trained to assess, diagnose, and manage patient care in all aspects of healthcare, including geriatric nursing, anesthesia, obstetrics, primary care, behavioral health, and they are an essential piece of all healthcare.
And I'm curious, turning over to you, Surani, how does someone become an advanced practice nurse and what do those requirements and pathways look like?
Well, I will say that there's the traditional pathway, which is what I and most of the nurse practitioners I know follow, which is, undergrad, then graduate school with a nurse practitioner degree that is a certification in that program. We are seeing a plethora of programs now. You can be a direct entry program candidate where you're going in with a bachelor's degree in something completely different and come out with a doctorate and nurse practitioner. It's quite remarkable. Things have changed probably more in the last 15 years than I have ever seen in the history of nurse practitioners and all other APRNs. But it's also true that our other two guests have a unique entry into their practices, which I think would be great for them to share, because we have the traditional college pathway, but I'd love to have Sheree and Elizabeth share how they got into their specialties as well.
Well, I definitely still took the traditional college pathway as well. I was just lucky enough to do that through my time in the Navy, through what we call duty under instruction. So I was really fortunate. The Navy has a strong clinical nurse specialist supportive group. So, but I did still need to take the 3 Ps, advanced patho, advanced pharmacy, and advanced physical assessment, as all APRNs are required to do. At the time, there really wasn't, when I graduated, there really wasn't that doctoral pathway. There was really that MSN pathway. And then, of course, certification, and then licensure as well. I know that Elizabeth, though, had a really unique entry into advanced practice nursing.
Yeah. So still, it was all the college pathway. So just to be clear, I did start out as a BSN. With the anesthesia program, there was a requirement for intensive care experience. So I had a total of 5 years of experience as a nurse in the ICU and the ER before. And then I was accepted into a scholarship program with the U.S. Army and went into the U.S. Army's graduate program in anesthesia nursing, proctored through UT Houston, but similar to Sheree, was active duty education. So I was on active duty learning to be an anesthesia provider or a CRNA. So
we've come a long way from diploma nursing, haven't we? It's quite remarkable.
Yeah.
Yes, absolutely. And I want to share too, the listeners of this podcast also come from many different backgrounds. A lot of them are nursing. Some of them might be in general healthcare roles. and they might not be as familiar with the different areas of advanced practice nursing. And so, since each of you represent these different areas of advanced practice, I'm wondering if you can talk a little bit about your specialties and how they differ in scope and responsibilities, because I think that not everyone might know what's the difference between a CNS and an NP and a CRNA. And so, Sheree, I'm curious if you could start with that and tell us more about the CNS specialty.
Right. So the word specialty or specialist is really at the core of the clinical nurse specialist role. Our clinical practice is deeply rooted in specialty, right? And that could be a specialty population or a specialty group, right? So that might be something like you specialize in maybe management of diabetic patients, or maybe you specialize in critical care. But really, what we all share in common is that we leverage this specialty expertise to improve outcomes. And we do that through direct patient care, leading evidence-based practice, and certainly optimizing policy and procedure at the organizational and systems level.
That's great. And Elizabeth, I'm curious if you could walk us through your journey as a CRNA and what that entails, because I think people are familiar with anesthesiology, and how that looks like for physicians, but curious if you could share about the CRNA specialty as well.
Happy to. Nurse anesthetists have a wide range of practice depending on where they're practicing at. In many states, they are practicing as an independent practitioner. LIP, a licensed independent practitioner. They're working on their own. They are not required to have somebody overseeing and signing orders or H&Ps. They do all of that work themselves. And recently in California, this was actually reinforced with the California AB 876, that CRNAs are qualified and practice independently. In a rural area, it's super essential. It's where I've chosen to do a majority of my practice was in rural anesthesia, and it's 100% independent. We can't find an anesthesiologist to work here. And so we do the same exact scope as an anesthesiologist in a rural area, including pain management, general anesthesia, sedation. A lot of times we're helping manage sedations in the intensive care unit and manage ventilated patients, and helping provide ER, diagnostic lumbar punctures, that sort of thing. So it's a whole scope of practice, but in a metropolitan area, a lot of times the practice is more of a team approach with an anesthesiologist and CRNAs working together.
Yeah, thank you for sharing that, because there is different levels of independence that you might see with these different specialties depending on the regions at times. So if it's rural, I know that could be also something we see with nurse practitioner scope as well. And I'm curious, Surani, if you could tell us more about the nurse practitioner role. We've talked about that a little bit in our podcast episodes before, but can you share a little bit more about the nurse practitioner role as well?
Sure. The nurse practitioners are found literally everywhere. So the concept for nurse practitioners actually started in California as a primary care provider, and it just has exploded from there. It was interesting that when you explore the history of nurse practitioners in California, you see family medicine nurse practitioners moving into the hospital setting very quickly, almost immediately, and delivering hospital-based care. They were doing rounding. They were working in the hospital settings in multiple specialties. And now when we just got done with our annual conference, and it was quite remarkable to see the number of nurse practitioners that work in literally every specialty you can possibly imagine. And they do everything. The only thing they do short of surgery is every line management that you can name, they do. Every tube insertion they can do, and even some procedures that used to be considered more complex are now considered kind of everyday procedures that you would do even in the ambulatory setting are being done by nurse practitioners. And so I would say that the entry into independent practice started with the bill that we've talked about in the past, Charlene, AB 890, and then Senate Bill 1451. And work continues to move forward with that concept because, as Elizabeth says, rural health is where you find a lot of nurse practitioners delivering care. They are obviously in big cities, working in huge healthcare organizations around the state, but the majority of primary care is really starting to be delivered by nurse practitioners and our PA colleagues out in the rural settings.
And then, Sheree, I have a question too about clinical nurse specialists because it's also a fairly specialized expertise in the CNS role. And I see a lot of people confuse a CNS and an NP, and I'm wondering if you can share a little bit of the differences between the two.
Yeah, it's interesting. I think, at the most basic level, when we talk about that question, I probably used to answer that. Well, nurse practitioners are in primary care and clinical nurse specialists are hospital based, but I don't think that's really the accurate answer anymore. Because I think both of us can be found in many ways. I think the difference, like the main difference that I see is that clinical nurse specialists really focus on system-based evidence-based practice, right? So looking at what does the evidence say, what is the best standard in care, and then how can we implement that across systems? And that takes many forms, right? We can implement that at the patient sphere of impact. So at the bedside, providing expert care. You might see a clinical nurse specialist that, specializes in Coumadin clinics, right? And that's their focus, but it's still a specialty. Where we also work in the nurse sphere of impact, right? So we might be using that specialty to train nurses, to make sure nurses are competent, to consult on difficult cases. So it really has, I think, become more blurry than when the roles first started. But there certainly is many differences, but there's also a lot of similarities. We both are skilled assessors. We're both skilled in treatment and in evidence-based practice, and bringing. We're both roles, I think, are really focused on patient outcomes.
Yes, and you mentioned the different settings too that you can find a CNS. They might be inpatient, they might be outpatient. And it makes me wonder too about the CRNA practice settings because I think typically people think about nurse anesthetists in an inpatient setting. I'm wondering, Elizabeth, if you can share, are there other settings where we might also find CRNAs?
Certainly. Most commonly it is inpatient operating rooms, but outpatient surgical centers, also pain management centers. There's a lot of CRNAs that were working in pain management clinics that provide those services and do a great job.
Great. Thank you all so much for sharing the additional information about the various advanced practice roles. And I want to talk more now about the current practice environment for APRNs. And Surani, I want to talk about specifically the demand for advanced practice nurses because, there has been so much progression and evolution of advanced practice nursing roles. And of course, the need for them has also changed over time. So can you share how that demand for APRNs has been changing in California?
Well, we don't make enough of them in California. That is certainly true, and I can attest that even in the last 20 years, to Sheree's point, the growth of programs in California has been through the roof. So you have seen traditional family medicine programs start to expand and include adult gero. They add psych-mental health NP options. You can do a post-master's certificate, a one-year certificate. If you're already a nurse practitioner in a specialty, you could do that and become a psych-mental health NP as well. And then all of the other specialties that are the APRNs that are starting to emerge. I think we don't have enough CNS schools in California. And we don't have enough CRNA programs in California or midwife programs, like all of them. So I think that that the number of people that we need in the state to take care of the population in the next 10, 20, 30 years is going to have to grow. And certainly we have people being trained from other places in the United States and coming into California to work. That transition can be a little rocky for our out-of-state colleagues that are coming into practice, say, as a CRNA, CNS, or an NP, or a midwife. But it is also difficult in any practice environment because we are continuing to face barriers in advancing into areas to deliver care. So while we have traditional spots where we are found, all APRNs, I, for instance, would love CNSs in the ambulatory setting because they are really the experts in driving evidence-based practice. And it is almost impossible to find a CNS able to work in the ambulatory setting, but certainly convincing your organizations that it's the right thing to do is one of, I think, the hardest first steps. So it's not just that we're going to struggle with a number of people that we have in the state, but it's also that healthcare organizations have got to start thinking into the future about what does patient care look like and what would benefit the delivery of patient care in every setting that we have moving forward. So I think that for me is really about taking down the barriers that have prevented APRNs from moving forward in practice. And I'm not talking about changing what we do. I'm just talking about changing where we're found and the recognition of the work that we do.
Right. And it sounds like the demand for APRNs can really be seen in the need for increased numbers of APRNs and then also increased need for different settings, different placements for them because there's just so much possibilities of the services that they can provide.
Right.
And it makes me wonder about other existing challenges that we might see that APRNs are facing. And Sheree, I'm curious if there's any additional challenges you might see, whether it's from a CNS perspective or other APRNs, but what else are they seeing in today's environments that might really be impacting their practice?
Well, I would be remiss in this opportunity I have 2 points, but the first one is probably more specific to the clinical nurse specialist role than all the APRN roles. But one of the biggest barriers I am seeing is role clarity. I am seeing roles that are advertised for the advanced nurse clinician or the nurse specialist, right? Where we can take somebody with a master's degree and say, we don't want to pay for a CNS. So instead, we're going to have this other nebulous term that we're going to use and maybe pay them less and hope that we get the same outcomes. So I think role clarity is absolutely important across all of our roles. But I think right now the clinical nurse specialist is facing it head on. But I would say a larger, if we're talking at APRNs, one of the larger challenges facing us right now is this tension about who controls delivery of healthcare, who controls reimbursement, what are the professional boundaries, right? I think in Surani and I's previous conversation, she used this great word resistance. And I was like, wow, that's it. That's the word, right? Primary care is really, I think, where this is most visible. It's high demand, it's revenue generating, and it's experiencing shortages. And so I think we might be, especially in the MP role, we are positioned as APRNs to solve this gap, right? But at the same time, if there's this back and forth pull that we're somehow taking the jobs or taking the reimbursement or taking the work, resistance to our scope, then we're not going to be able to be that solution to those gaps, particularly as we've mentioned in those rural and underserved areas.
Right. And it sounds like when it comes to APRN practice, there's really this coupled challenge that we see. And from the team role perspective, there is this challenge of role clarity. So as all these different roles evolve and as more complexities are occurring in the different care settings, there is more blurred lines in terms of who does what. And that can especially be seen in nursing roles and advanced practice nursing roles. And so the question of who does what becomes a really big one. And then also scope creep is a little bit of that part of that as well. So
absolutely.
Mm-hmm. And I'm curious too, Elizabeth, from your perspective, from leadership, because from the perspective of a chief nursing officer or other nurse leaders who might be working with APRNs as part of a larger system or larger team, what would you say are best practices for effectively integrating APRNs?
I think it's absolutely essential that CNOs meet with their APRN groups and really understand their scope of practice, really advocate for a practice at the highest level of their license. It facilitates care at that organization and ensures patients are getting the care they need. And it really promotes a safe, collaborative environment across the board with all of the specialties. I know one of the first times I reported up to a CNO, and she and I chatted, and she told me she had no idea what I did, what my role was. And I think that's quite common across the board, is that many CNOs don't understand the role. I think that's slowly changing. I know in my organization, our APRN leadership is invited to all of our CNO leadership meetings as well, and they provide updates and work with scope of practice and onboarding, orientation, making sure we're doing the best we can to provide that advanced practice role.
Right. There can be challenges when you think of the perspective of a CNO if they don't have the background or the clinical background as an advanced practice registered nurse. And given that there's so many different types of APRN roles, it could be really easy to have a CNO who might not understand all of those details and nuances when it comes to, these 4 different APRN roles. So that is a lot of information, and that is a big gap potentially. So what you're saying, in terms of that visibility from the CNO and having that collaboration, so there could be more thoughtful ways to integrate APRNs, could be a best practice, and really having more of that dialogue, I would say.
Definitely.
And there's also many challenges when we zoom out more and think about policy, right, from a statewide perspective. And Surani, you are currently our co-chair for our ACNL Health Policy Committee. Mm-hmm. And of course, our favorite person to talk to when it comes to recent and upcoming legislation. And when we zoom out and when we think about legislation right now and what's in the pipeline, could you walk us through what is in the pipeline right now for advanced practice nurses?
Well, I would say that every year we are seeing legislation that is seeking to kind of unveil the availability, right, of APRNs in the workforce everywhere, in every setting. And certainly true with the ACNL Health Policy Committee, too. The importance of supporting all of our colleagues, not just APRNs, but also nursing legislation, in recognizing the value of nurses in every setting, and certainly APRNs and delivery of care. So I think what the future is holding, we had a bunch of CRNA bills in the last 2 years, and we have the nurse midwives have a couple of bills that are going to be active this year. The nurse practitioners haven't yet released anything, but we certainly are working on addressing the issues that are being generated by us stepping into more independent role. And certainly the CRNAs addressed that in the legislation just recently, because the way CRNAs got independence was an interesting route. And so codifying it into law was the most important thing to do, which is why that legislation was put forward for CRNAs. And so the same is true with the CNMs. The midwives also have independence in certain settings. So there is a continual cleanup, I should say, a legislative cleanup of the language, because things get misinterpreted or put into practice that are not following the law. And so going in to clean that up and make the law more crystal clear is important, so our APRN colleagues can continue to deliver the care that our patients in the state of California so much deserve. So I think that's more of what's coming down the pipeline than anything. It's just constantly cleaning up and looking at where our barriers are. We've got a lot of barriers around practice management and ownership that need to be addressed. So at this point, all of us could own a nursing corporation, but we don't actually have the legal authority to have patients. You need a medical corporation for that. So I think that is the next big topic that will be on everyone's minds in the coming couple of years.
Right. And it's almost as though with all of the advancements we've made in nursing, it's almost as though legislation is constantly trying to keep up with all the changes and
Yes.
all the meeting needs, right?
Yes, absolutely.
And I wanted to ask too, how can people find information about this pipeline? What would you suggest if they are wanting to stay up to date?
Oh, well, ACNL, we have great information. I would encourage you to join committees. We have a very active committees in ACNL, and certainly the Health Policy Committee is a very active one. But I want to also encourage all the listeners that if they are an APRN of a different stripe, that you get involved with your professional associations, because membership is really the most important way to stay abreast of what's going on in your role. And I think the questions that Sheree brought up about role clarity are spot on. And we certainly, the nurse practitioners have certainly spent a number of years supporting our CNS colleagues. I may be in Sacramento talking about an NP bill, but if there is a CNS bill that is adjacent, I'm going to talk about that as well, because I work with CNSs and I know the value that they bring to the organization. And certainly CRNAs, to Elizabeth's point, recognizing the value of CRNAs in every setting. There has been for so many years this concept that they're just hospital based because they can be, supervised by anesthesiology is, a very outdated idea. And so I would argue that the CRNAs in the state of California are actually one of the more active professional groups, because almost 100% of graduates coming out of CRNA school belong to their state association. So ACNL is one of those really wonderful groups that kind of crosses all specialties and really gets nurse leaders to become more aware of all of the things that are happening in the state, and both on the ambulatory side and the acute side. So I say, get involved and read what we have to say. We have a great newsletter that the health policy team puts out, but every professional association for all of the roles that we've talked about today, including the nurse midwives, they have wonderful updates on their websites that you can easily find and research, and certainly reach out to them if you need more information about a particular topic as it relates to your healthcare organization.
Yes, there's a lot of resources we could find within ACNL, within different professional nursing organizations. And that makes me wonder, too, about nurse leaders within different healthcare systems. And Elizabeth, just wanted to hear from you in terms of nursing leadership supporting APRNs. How would you say they can do so both operationally and through advocacy, when we consider the different challenges that we discussed today?
So a lot of that is really encouraging the APRNs to get involved, to join their associations. And the nice thing about anesthesia, I don't know, when I was in school, it was mandatory that we signed up for AANA. And so we were all mandatory members as students, and just kept that through the years. And then, California Association of Nurse Anesthetists is a great organization, branch off of that national organization. I think nurse leaders have to support that involvement, really encourage their APRNs to get involved in the committees, but also to come to the local hospital meetings, to come to the med staff meetings. Even if you're not a voting member, having your voice heard is absolutely essential. If your voice is never heard because you don't come and you don't speak up, you'll never affect change. And the only way to do that is to be involved. Totally agree with Surani.
And that's a great point that you mentioned too about membership, because the reason why I joined ACNL in my nursing career is because my chief nursing officer at the time, really encouraged the membership, and she paid for my membership and my registration for my first ACNL conference, and I never left after that. So it makes a huge impact when there's that encouragement and role modeling for organizations and for involvement. So that's a really great point to think about. And when we think about the future too, looking ahead 5 years, Sheree, I'm curious if you can share, how do you see all advanced practice nursing evolving in California and nationally?
So I would again say twofold. The first is specialty care gaps. We have these specialty care gaps that APRNs are so ready to fill. And the ones that come to mind first for me are the shortage of ECMO perfusionists, right? And so we're seeing an increase in ECMO nurse specialists. I know many CNSs now that is their specialty of practice. But that's just one example of how we can fill these gaps. Certainly in the post-acute world, our healthcare system is continuing to move to a post-acute care environment, right? Not just that acute care hospital. And APRNs are well positioned to fill those specialty gaps as well. We have a CNS, Narina, who, she oversees post-acute facilities up and down the state of California. It's just amazing. That is her area of specialty. And then, of course, I would be remiss not to bring it back to my earlier topic, which is, that really understanding that primary care need. So the specialty care need, but then on the opposite side of the spectrum, we really need to address that primary care need. And I think through advocacy, through policy, as a clinical nurse specialist, we are pursuing full practice authority in the state of California. We have to support the nurse practitioners. We have to support all those APRN roles if we're going to meet these gaps in care in both the primary care setting and those specialty care areas.
Yes, so really thinking about advanced practice nursing in the future is really thinking about advancing this practice for us, right? So that's
Absolutely.
whether that's more specialty care or more focus on primary care as well, and more integration in that. These are all really key ideas to keep in mind for the future and talk about now, so we could prepare for that advancement. And as we wrap up today, if there's any final words that you'd like to share with our listeners, I'd invite you all to share.
Well, I'm just going to say, get involved. So you don't have to become an advanced practice nurse. You can be a nurse leader, but staying involved with your APRNs, I think, is a key way to be successful in your organization.
You absolutely were reading my mind. Getting involved was exactly the word.
Yep.
It makes such a difference when we have voices from up and down the state in our organizations. It increases the support, and this is how we will move these initiatives forward. If we want to progress over 5 years, it can't be just a few voices. It's got to be all of our voices together. Absolutely.
And if you're a nursing leader, know your APRNs, what their scope of practice is, and promote them. They're going to be providing the care to all of us as we need it.
Right. And thank you all so much. That was so much wisdom that you shared with us today, and really appreciate you all for being here and for representing advanced practice nursing.
Thank you.
Thank you so much for having me.
Our guests today were Surani Hayre-Kwan, System Director for Advanced Practice Providers at Providence, Sheree Scott, Associate Professor and Director for Clinical Nurse Specialist Programs at University of San Diego, and Elizabeth Pulatie, Chief Nursing Executive Officer and Vice President of Patient Care Services at Mercy Medical Center, Mount Shasta. We'd love to hear your feedback. Email us at social media at acnl.org and connect with us on LinkedIn and Facebook at ACNL Nurse. And as always, if you like the show, please remember to rate, review, and share. ACNL in Action is brought to you by the Association of California Nurse Leaders, with new episodes on the first Friday of every month. To learn more about the show or ACNL in general, visit us at acnl.org. Thank you for listening.